Good afternoon, ladies and gentlemen. The Committee on General Government Appropriation, and Housing convenes this budget hearing. The budget hearing notices were given to the media on Monday, May 6th, and Friday, May 10th, and today is Tuesday, May 14th. The committee will hear and accept testimonies, both oral and written, on the following, which is the Guam Memorial Hospital 2020 budget hearing. I'd like to acknowledge colleagues that have joined me today. I have Speaker Tina Munoz Barnes. I have, I'll go down to my far left, would be Senator Jim Moylan, Senator Joe Pidu Terlai. We have Senator Sabina Perez. To my farthest right would be Senator Clinton Rigel, then Senator Luis Munoz, Senator Amanda Shelton, and the Oversight Chair for GMH would be Senator Therese Terlai. The conduct of this public hearing shall be as follows. Those testifying will be recognized in the order of sign up on the sign-in sheet. And currently we have basically all the management folks here, which is great. Written testimony may be read. A lengthy written testimony should be summarized to about 5 minutes. We'll waive that because we're going to talk about your budget. All right, Ms. Posadas? Please provide our legislative staff with your written testimony for photocopying, if you have any. Testimony shall be confined to the substance. We're talking about the budget. We may talk about 2019, the current budget, in addition to 2020, okay? Individuals will be allowed to present oral testimony only once. Once you're done, you may be asked to remain in the room for questions or for additional testimony as may be desired by members of the panel. Proper form and decorum shall be practiced by all present in the public hearing room for the proceedings. Individuals who fail to maintain proper form decorum may be restricted from providing oral testimony and or may be asked to leave or be escorted, removed from the room. Fair warning, if proper form and decorum is not conducted, you will be removed from the room. Your presence will not be needed. Okay, when you speak, please make sure that the microphone is on and that you speak into the microphone. Please state your name. We will now begin with the Guam Memorial Hospital's FY2020 budget. And we have present today is Ms. Lilian Posadas, Ms. Benita Manglona, Ms. Jolene Uggan, and Ms. Annie Berdalio. I know one of you is a doctor. That's you, right, Ms. Berdalio? Or you? Both of you. I like how you pointed at her and you're both. Oh, okay. Doing one of those, right? The two fingers, right? Okay. All right, doctors. We'll start out with Senator Light. Do you want to make any introduction, or we'll just have Ms. Posadas? Ma'am, please.
Thank you, sir. Buenas and Hafide, Senator Joseph Agustin, Chairman of the Committee on General Government Operations, Appropriations, and Housing, and all senators of the committee. Thank you for giving us this opportunity to present and defend our one and only public government hospitals budget for fiscal year 2020. Before I go any further, I wanted to introduce the executive team, but you already kind of beat me to it. I do want to introduce Yuka Echanova to my right. She is our assistant CFO, and you already met the others. So there is another executive member, Mr. William Kandu. He is the Associate Administrator of Operations. Unfortunately, he's not with us because he has an emergency, family emergency, so he's off island right now. Other members of our executive leadership are Ms. Danielle Manglona. She is the Administrator of the Regulatory Compliance and Risk Management. And Christine Tucaro, she is Assistant Administrator of Nursing Services. And Dr. Vincent Duenas, Assistant Administrator of Professional Support Services. This week we're celebrating Hospital Week, and today is the day we celebrate and honor all our nurses and nursing staff. But we're here before you to defend and tell our stories that will hopefully help you or help this legislature as well as the public gain a perspective of how and why we need the continued support to keep the hospital operating as confidently, efficiently, reliably, and safely as possible. Just to give everyone a background, historical background, because I know some of you, a lot of you are young, probably could be my grandchild because I am old already, so. But I wanted to give you a little bit of a historical background. The Guam Memorial Hospital was originally constructed at Oka Point in 1956 For many years, the U.S. government provided free hospital and health care services to the people of Guam. The U.S. Naval Forces assumed responsibility for the island's medical needs when the United States took formal possession of Guam. These services continued with the U.S. Navy's delivery of care after World War II and culminated with the donation of a 230-bed facility that was named GMH to the government of Guam's Department of Public Health and Welfare. That was what it was back then. In 1964, the Guam Memorial Hospital was established as a line agency of the government of Guam's executive branch. This creation separated the administration of hospital services from community health services provided by the Department of Public Health and Welfare. In 1977, the Guam Memorial Hospital Authority was created as a public corporation and has since been operating as a governmental nonprofit institution and serving people of Guam under the governance of a 9-member board of trustees. As the only civilian public hospital, we are mandated to serve all individuals, regardless of their ability to pay. In 1978, the medical center of the Marianas facility was initially constructed by the Catholic Diocese to serve as private maternal child health facility. Unfortunately, financial difficulties prompted the diocese to consider the sale of the facility to meet the government's needs to replace its old facility at Oka Point. Along with the funds for the initial purchase of this facility, federal funds were also provided for the expansion of the facility to allow the consolidation of all the services on a single campus, which is where we are right now. In 1987, GMH relocated all its acute care hospital services and the skilled nursing facility. In 1996, GMH completed construction of its skilled nursing facility in Barragata Heights with a capacity of 60 long-term care beds. However, it is presently certified by CMS to operate at a capacity of 40 beds. Although, because of our shortage of staff nurses, we can only accommodate 20 residents in that facility. The current organizational capacity, services, and human resources are Guam Memorial Hospital remains the only civilian public acute care hospital with a licensed bed capacity of 161 acute care beds. The medical specialties include the cardiac cath lab, CCU, ICU, that's the intensive care unit, RER, urgent care, interventional radiology, labor and delivery, OB nursery and NICU, pediatrics intensive care unit, the medical telemetry, progressive care unit, operating room, and the post-anesthesia care unit. Its type of healthcare services include inpatient adult acute care, the long-term care at Barragata Heights, maternal child health, and as you know, we are the only facility on island that provides service to the maternal child health population. GRMC closed its doors back in November, so we are it for maternal child health services. With a total staffing of 934 FTEs and 81 part-time employees or positions, the above services are led and managed by the following 5 major service divisions, and that's medical, nursing, professional support, fiscal, and operations/administration. I'd like to add that we also have an extended entity, that's the Department of Corrections. You know, per the consent decree, we are mandated to provide the services at the Manila and at the Agana facility. So we operate a clinic there, and we provide all the pharmaceutical supplies for those inmates who need medications. And so, you know, that's a part of our expense there and resources that we provide. During the last 25 years, GMH completed the construction of hospital capital improvement projects, such as the expansion of the emergency department and the ICU. The ICU right now has a capacity of 14 beds. However, because of our severe shortage of nurses, we can only accommodate 6 ICU level of care patients in our ICU unit. And a lot of times when patients come into the emergency room and they need the ICU bed, we cannot accommodate them, so they stay in the emergency room, you know, which is, you know, again, the best that we can provide, especially given that we do have the doctors on duty all the time. So they're still getting really good care in the emergency room. The Guam Memorial Hospital's total interior square footage is approximately 312,351 square footage. In April 2012, a hospital expansion feasibility study was conducted, and based on the study, the leadership at that time made a decision to relocate and transfer 50 staff out of that dilapidated Z-wing. The staff were of the accounting, fiscal, social services. We had to move them out of there because it was just not safe. So to accommodate them, we had to close half of our cafeteria to then put them in that area. And it's quite a tight fit in there, but you know, we don't have much space, but we utilize what we can. The other infrastructure that's really important is GMHA's electrical distribution panel, and I've mentioned this before. It's a 43-year-old electrical panel, and I'm just very concerned that, you know, if we don't do something to replace it soon, I don't want to be caught in a situation where we don't have power. We do have generator backup, but we can only, you know, use those not for long, but we really need, and I want to emphasize, we really need to replace the electrical panel, and it is in our capital budget that we've tagged it at $6 million. Also indicated in the hospital expansion feasibility study is the dilapidated roof systems at GMH. So we also, again, put that in our capital improvement budget to replace that at a tag of $5 million. Another top priority with regards to our infrastructure concern is the current state of the heating, ventilation, and air conditioning, which is our HVAC system. Again, because the building was constructed, you know, 40 years ago, we're struggling with that HVAC system. We have 60 air handling units and a large number of fan coil units in the patient rooms that really need to be replaced. And then the last critical and urgent infrastructure need is the electronic health record, electronic medical record, that's our EHR. We currently have the clinical optimum that Cantata administers and supports, but they just notified us in February that they will sunset that system, EHR, and so we're now prompting and exploring options to then replace that. We have until December 2020 to replace it, but we don't want to wait till that time when Cantata is phased out. We want to make sure we at least transition, particularly the patient data and the records. We want to make sure that those are transferred or converted into the new system accordingly and accurately and completely. And so now I'd like to refer you to the handout that we've given you, that we prepared. These are the PowerPoint presentation slides that we printed. We didn't want to do a multimedia, but we've got documents, copies of it.
Ms. Posadas, in the
Yes, sir.
future, have your staff provide that to my staff. It's not for your staff to work
Yes, sir.
around,
We just
okay?
finally, we flushed it out and we finalized it this morning. So I apologize that we didn't get it.
But
to
still,
you in time.
when you arrive, just pass it on. We'll take care of it, and we would have gotten it out a lot earlier for you.
Okay.
And is your staff ready to put it up on PowerPoint?
No, we're not going to do multimedia PowerPoint. We're
Okay.
just going to go with the printed
All right.
slides that you
Okay.
have before you.
Thank you.
And so the second slide there, fiscal year 2020 budget, we're looking at a budget of $191 million. For operations, the expense will be $134 million. For critical equipment and upgrades, $46 million. And the urgent infrastructure repairs, which I mentioned earlier, the electrical panel and the roof repair. So that comes out to be a total of $191 million that we're going to need for 2020. Again, just to give you another perspective in terms of direct patient care, how complex the hospital is in its structure. Do you want to go ahead and?
I'm Dr. Annie Berdalio. I'm the medical director, and I will turn your attention to all the services that we do provide at the hospital. We have several direct clinical care divisions, medical, nursing, the professional support, and as Ms. Posada said, the Department of Corrections. We provide fairly comprehensive medical services for all patients who arrive at our doors. To support the operation, we also have indirect patient care divisions. So the fiscal team, the hospital administration, compliance that helps us meet regulations, and of course the operations, which really is the facility maintenance, housekeeping, communications, human resources, and basically the structure of what runs the organization. If you turn to the operating budget, the fiscal year 2020 budget, this graph really just demonstrates that about 75% of our budget is allocated to direct patient care. So our admin support make up about 25%. And you've heard Ms. Posadas talk about the nursing shortage. This budget includes a raise for our nurses to help the hospital keep the nurses, rather than the nurses going out and working in other nursing sectors of the community. The unique thing about a hospital is it's a 24/7 operation. So when somebody says we have 900 to 1,000 employees, it's because we run 24/7. And we have to staff the entire hospital for 3 8-hour shifts. So it's not really a lot of people for as large a facility and for as many services that we do provide. If you look at the graph over the last 10 years, we've actually allocated more of our budget, again, to direct patient care. So in 1998, it was about 50-50. Now it's more in the 70-30, and for 2020, it's 75-25. If you turn to the next page, the American Hospital Association, I looked at their surveys for hospitals similar in our size, for hospitals that have between 100 to 199 beds, and again, we are at 161 acute care beds and about 180 total. They have a full-time staff. The mean was 646 full-time employees, 263 part-time employees, so it's 909. So again, we're not that far off with our staff. Their average admissions a year was 5,700. Ours is this year going to be 9,600. When GRMC opened, we were at 12,000 admissions. We went down to 9,000, and then probably when the labor and delivery services closed, it went down. It came back up a little bit. So this year it's going to be 9,600 admissions is estimated for the year. The average cost to provide the service is about $2,000, and that's the average of a similar size hospital. For us, it runs between $2,000 and $2,200. So we're not really that far off the national average, and our average reimbursement is about $1,600 a day. So we are going to always have a shortfall. In our revenue projection, we are projected to bring in about $104 million. So we are asking for a $30 million subsidy for operations. This represents about 22% of our expenses. And if you look on the next page, you can see why. We have a payer mix of about 15% of our patients are self-pay patients. So the collection rate in that category of patients is somewhere in the 30 to 40% range, and that's only because we garnish taxes. If we did not do that, the collection rate would be a lot lower. If you look, about 50% of our patients are represented by what we call the 3Ms, Medicaid, Medicare, and MIP. The average reimbursement for that is about 70%. So again, we run into another 30% shortfall over what it costs for us to provide care. Benita has worked very hard to get Medicare to recognize that our costs are higher, and so we've had some success at getting our rebase rate elevated a little bit, and that is included in the projections for the revenue. So it went up a few million. The other thing is that Medicaid and MIP do not allow rebasement. So even though we can go after the Medicare dollars from the old bills, our state plan does not allow us to recoup those from the Medicaid portion of our payer. And then the third-party payer patients, as most of you know, because you have government insurance, this pie is not also 100% collectible. Most of our patients have deductibles that are quite large. They also have 20% co-payments that may eventually get converted into the self-pay portion of our population. So if you look at our shortfall, it's really about 20%. Our non-paying or very difficult to collect or underinsured, as well as our Medicare and Medicaid reimbursements, are typically about 20% short. So in my mind, it's pretty easy to see why we always have a shortfall. If you look at the graph, this shows the average cost at discharge for Medicare patients. It's somewhere in the $14,000 range. The reimbursement is somewhere in the $10,800 range. So again, that 20 to 30% shortfall is basically explains why we're here to ask to make that up, because we have no other way of making it up. I think in terms of hospital margins across the nation, they are in the 1 to 3% range. If you have a really good hospital, about 30% of hospitals do not make enough revenue to cover their expenses. So we're not alone. We're in the 30%. And now, because of technology, some of the top performing hospitals are starting to see their margins creep up. And that's because of technology. The last slide in there that you might want to look at is the 2018 revenues. Again, that still had it included the 30 million, give or take, subsidy that came from the pharmaceutical fund, the Healthy Futures Fund, and then there are some grants. We have the Family Birth Center that is going to be funded by the Department of Agriculture. The money is there and has already been approved. It's just the interim financing that Geeta's working on. It's also, we got caught in the immigration and lack of construction workers to move some of these projects forward. So we do work with the partners. We had a meeting with the Department of Labor, who has grants to train our workforce in healthcare. So they have $1 million grant that they're coming to us to help train our workforce with. And then there's also the U.S. Department of Public Health that we met with that has some loan forgiveness and loan repayment programs to attract physicians, young physicians coming out of training, so that we can help attract them to our community. So part of this budget, and I'd like to move on to the infrastructure and the improvement. I think most of this data really explains why we're short. I don't think it's reasonable to think we can generate by increasing our collections, I think we already collect from the local insurers pretty close to what they owe us. A lot of the 20 or 30% that we're not collecting over what we're charging is based on the patient co-payments or the patient deductibles. The denial rate and the disputed make up a pretty small portion. So again, technology, having more utilization review can help us recoup some of that, but it's not going to make up for the 20% of patients that come into our facility that may not have the ability to pay. So as a doctor, and Dr. Uggen here, we're very fortunate to have, is an intensivist. So she works in the intensive care unit. So the sickest of the sick who come in, she takes care of them. The technology that's required to take care of these patients really is available in many of the hospitals in the States. Generally, we lag a little bit behind in our delivery of health care. But in the last 20 years, and I've been practicing here for 25 years this year, the advances in medical care have been incredible. Just like going from the Apple computer in 1984 to our computer is right here. Healthcare, the technology has accelerated at this incredible speed. So when we are trying to invite young physicians like Dr. Uggen here, we have surgical residents that are ready to come out here to work, and we have an infrastructure at our hospital that is from the 1970s. It's hard to replace those of us who are getting older. I have to train a younger physician, but she can't come out and do anything because we don't have any of the equipment that she's training on. The technology that's required to provide modern health care just doesn't exist in a large amount at the hospital. And that's why we are here to ask for this extra $46 million. This is a long time coming. They have asked for capital improvement expenditures over the last few years, every year. Ms. Posadas talked about the electrical distribution system. We talk about the HVAC system. I invite any of you to come visit our hospital on a nice stormy week. You know how we have storms. We don't have rain for a long time, but then we'll have 5 days of rain and lots of rain, and it comes right through the elevator shaft. Any of you who have been there near a typhoon have noticed all the sheets and pillowcases lined up on the windowsills, on the floors, because the roof actually leaks. When we want to invest in every machine that Dr. Uggen uses in her ICU is connected to a computer. We just upgraded our pharmacy. Now we have a Pyxis system, and that's a recommendation by CMS to avoid medication errors. Those medications in those machines are linked to the patient via computer. That prevents human error. So these are patient safety issues. We can't invest in a $20 million computer system if we don't have the infrastructure to support it. If we plug in our $20 million record machine and it explodes because our electrical infrastructure is designed for 70, I'm afraid to plug anything into an outlet, honestly. So that is the struggle that we have. We are trying to, we have radiologists. We got 2 brand new CAT scan machines and found out that the software that runs them, because you know it's not an imaging machine, it's a computer. Ultrasounds are computers. So if we don't have the software, or the software, we bought the machine, but somehow it didn't come with the updated software because it took us 2 years to fund it, and then another 2 years to actually have it ride the ship into our, and then another year to put it inside the room. And then we plug it in and we found out the software is 5 years old and it hasn't been upgraded. These are the issues that we are going to face. And CMS comes out here and they deal with hospitals. I was quoting that American Hospital Association website. So we are probably going to defer our stage 3 medical record. So our electronic medical record, we get a CMS, we get money from CMS to help us get these records. So we just, because our record is sunsetting, we are going to defer stage 3. 80% of the hospitals our size are at stage 4 to 7. So we're not even in that level, and we have to defer it till after 2020 because our EHR doesn't have the support, the clinical support. It's not that the EHR won't work after 2020, it's just that from now on, if we have any support issues, they're not going to fix it. They're cutting out that part of it, and it's almost like the CAT scan machine with the 5-year-old software. If we order supplies and we order IV sets from the States to supply our ICU, they're designed to be connected to a computer system. If we don't have a computer system, we can't run the IV. I mean, that's the difference between our technology and current technology. That doesn't count where technology is going to be 5 years from now. 5 years from now, all of you will be wearing a watch that will be talking to Dr. Uggan. You won't be talking to me because you have to actually call me, but Dr. Uggan's phone will attach to all of your heart rates and your blood pressures. That's where healthcare is going. And if we wait before we invest in some of this important infrastructure, we're not going to meet the needs of our patients. And in our minds, the hospital doesn't stand alone to take care of our community. We need to connect with public health. We actually need to track everybody here and their healthcare problems because that's how we design our healthcare system for the island. And if you think you're not funding all the healthcare on the island, you are. You're funding it through GovGuam premiums. You're funding it through subsidies to the hospital. You're funding it through the Medicaid and MIP matches that you're putting in there. A large amount of our healthcare expenditure is government provided. So I think it's worthwhile to invest in this infrastructure. And I'll have Lillian go over the details of those.
You all have a copy of our 2020 budget, right? So, sorry, at the back part of it, we have then the capital, we're calling it critical and urgent infrastructure that we need. So for the operating divisions, we've got the EHR that we've been talking about. Do you have the budget? We submitted it. No copies? We provided the legislature on April 15 copies of our budget.
I think, my colleagues, you were all handed a copy of the budget. I
Okay,
hope you brought it all. The budget of GMHA.
correct. Yes.
That was all presented to the legislature and all passed out to every senator.
Right.
Okay.
We delivered it. So basically then, this is what we've got in terms of the critical and urgent infrastructure and upgrades that we really need to have the legislature support us in securing the funds for this. We actually scrubbed this CIP, this upgrade list, when we met with each of the managers, because they had a long list of items that they wanted. But, you know, again, we're trying to be practical and reasonable, and not to be really very overwhelming, because there'll be other years that, you know, we're going to need to then request for these critical equipment. But for now, this is what we felt were the priority.
Ms. Posadas, that's referring to the capital budget section, right?
Yes, sir.
Okay, I just wanted to make
That's
sure.
what I'm referencing. The red tab at the back?
The red tag in the back, right before the current staffing. Ms. Posadas, as, you know, as we're looking at, as you move to the capital projects, and as we look at your budget, that's all under the additional funding requirement, am I correct?
It's all under what we're requesting from the legislature, correct? The 46 million plus the 11 million. So we're requesting for the 87 million is what we're requesting, because 134,
Okay, stand by on that one. Now,
134 is
we
the
go to-
operations.
You go to your front of your budget, under the summary, you have a consolidated budget. You have a total funding identified, it's 129, and your additional funding requirement is 61. Is there,
That's correct, sir.
so it's 61 million additional is what you're asking for?
Yes, because the $30 million we were asking for, I think we've identified 26 million in, for the pharmaceutical fund and the Healthy Futures Fund. So that 30 million we're short by 4, and then you add that to the 57 million, and that's where the 61 million comes from.
Okay, let's go, we're at page 1, correct? On the very bottom, it says funding sources, correct? Operating revenue, 104. Pharmaceutical fund, 19. Healthy Future Funds, 5. Previous year, it was more. You went down, okay. Not a problem. Limited gaming, 600,000, total of 25, correct? Are we tracking? I'm looking at the same document you guys gave us, okay, Doc? Ms. Posadas?
25.8.
Total is 61 million, correct?
25.8 is what you're referring to?
Yeah,
The total
25.8,
funding
Yes.
identified
Right.
is 129 million?
and then additional 61 is what you're asking for, correct?
Yes, sir.
Okay,
Yes.
and that's what you're asking the legislature to fine you, 61 million, right?
Yes, sir.
Outstanding, okay. We'll see how that works. Okay, so that's not,
That's in addition to what has been identified already.
yeah, I understand. Everybody needs to understand, everybody watching on TV is that you're not the first budget, and everybody's gonna say GMH is important. I have no doubt about that. No difference, DOE says they're important. Everybody's gonna say they're important. Everybody plays a role. But we all have to understand is we're always gonna ask the question, what happened yesterday? What happened the day before yesterday? And what is being done to fix what should be fixed today? Because we'll ask you later, as you finish off what you're finishing off, about your current budget, and then we'll move forward from there. Okay? Thank you.
So I think I think.
You're pretty much done?
Yeah, I think
Okay.
the breakdown was really that 11 million was the roof and the electrical panel together, and then it was a 20 million plus for the electronic medical record plus the expertise to analyze and design the system so that we don't fall into the same issue. And then the rest of the budget is really some of the critical equipment and the software updates at radiology and some of the critical supplies that, again, we've needed for a very long time.
All right. I'd like to also recognize my colleagues that have joined us also, Senator Kelly March Taitanu and Senator Jim Moylan. And to my far right, I think there's Senator Eugene Biscoli and Senator Tello have joined us. There's a good handful here. So you're pretty much done presentation, right? Okay, great. I got a lot of questions, but I'm going to ask my colleagues to. Speaker, do you have any questions? And then we'll float it around among everybody.
Thank you, Mr. Chair. I'd like to thank the panel for being here this afternoon. And Dr. Haney, thank you so very much, and Lillian for sharing the scrubbed version of the budget. As we look at the budget digest here, but we look at an easier read on the scrubbed budget that you're looking at. You did ask for 57 million in critical equipment and upgrades and urgent infrastructure repairs. And as I was looking at the back pages of that, it shows that the roofing and the electrical repairs are that much more needed than what you have in the digest. So I wanted to ask you, was the 11 million based on the urgent infrastructure repairs, it's the complete, the 11, because you're asking for 57 million for capital improvement. So 11 million is for the urgent infrastructure repairs, which is the
roof,
the roof
repair and the electrical panel, the electrical distribution system, yes.
And have there been a detailed breakdown of that to suffice the 11 million requested for?
I believe the electrical panel has already been analyzed, and that was the price to replace it. Unfortunately, Mr. Kando is the guy who does the operations part, and he was caught away
For an
just
emergency.
yesterday. Yeah.
So I'm hoping that we can at least get an update based on the 11 million for that, because it's very important. Mr. Chair, one thing that has been brought to my attention that I did bring up to some of the panel members here was several terms ago we did do the looking at new resources coming in. We did look at the labor and delivery, and we gave the funding source to that, and we understand that that may not be a full GMH thing, but that you're working with the government, GITA, in as far as following it through, because I personally believe that if labor and delivery is fully optional and working, that we would have more funds coming in to help out and assist. Is that also an analogy? Any penny counts. So maybe what I wanted to ask was the update on that component first, because I know that that is a major generating component of the hospital.
This is the family birthing, right, that you're talking about?
No, I'm
MCH?
talking about the whole. I was just told when I was there yesterday, when I asked about the labor and delivery and why it wasn't updated and refurbished and done to add the extra rooms, that you know, I said in my head that if that was completed based on the funding that the legislature has given in the past, you know, that we could probably see more funding coming in. But they said that there may be I mean, the reason why it's not built is because I guess GITA
There was some issues with regards to the interim financing that GITA put out for a bid, and the financial institution that responded, there were some issues between that financial institution that they wanted to put in a parameter, some kind of a requirement that USDA did not agree to. So therefore, that request and that proposal is now null and void. And we had a hearing, an update with the GITA. And so we have to go through another process. What we've already done on our part is we requested a new A&E and certified to give us an updated construction cost. Because back then, it was estimated to be $9 million for the construction. You know, that was, several years ago. So we're looking at a construction cost of anywhere from 11 to 12 million. And so GITA will need to send out a bid for interim financing. We haven't heard if GITA has already done that. So once that's done and we secure an interim financial institution, we then proceed with an RFP for the construction. Granted again that USDA will give us a green light to proceed with that RFP. So right now, it's at a stall.
But it's still operating then?
The labor and delivery, the existing, of course, we have that. That has not changed. And, you know, we have purchased some labor and delivery beds to augment that. And so we continue with what we've got currently for our labor and delivery and our OB ward and our nursery. That is our MCH service. Does that
No,
answer your
so
question?
I just wanted to make sure, because as I think of the hospital, I think of any resources that can come into the hospital that we'll be able to find to help the hospital.
Sure.
Based on what comes in and the rebasing and all that you have mentioned, it's still not enough for the 61 million that's
Well,
requested.
Senator, I think although traditionally labor and delivery has been a money generating area, I think the economics of healthcare has changed that a little bit. I don't know the details of why that is. So if you're thinking if we got that new facility in, that all of a sudden we make up more revenue, we're the only show in town. So we provide those services at just what it costs us at the moment, which is a lot less than a brand new $4 million and probably going to be a $6 million facility. So it's not like we're going to get more patients because it's the only place people can have their babies now. The birthing center it is very small, but it was really GRMC that took half of those deliveries, but those deliveries are back in the house without any infrastructure improvement. So I don't think we'll recognize higher revenues from that project, but we will recognize better patient care. We will recognize that moms and babies can stay together the whole time they're there. So I think the service is going to be much better once we update that part of the facility. And it's interesting about that is because when we add a whole new facility like that, we have to improve our HVAC system. We have to improve our electrical distribution to get all the computers that go into servicing that section. So the other interesting thing about regulation and CMS is when you start to upgrade services, they demand more. So when you have a one-room, shack, they don't require you to have anything. They require you not to have air conditioner. You can go to any hospital in the farm town and they don't require them to have upgrades. But when you perform neurosurgery, when you have interventional radiology saving stroke victims, yeah, they require you to have the infrastructure to support that. You can't say, well, yes, we have that, but we don't have a good air vac system. I mean, it kind of goes hand in hand. So over the years, as we've been improving or providing these services, the technology and the infrastructure, we've been not quite funding, and now we're now they're demanding that we put resources in that part of the system that we've gotten away with for a while because we haven't funded it.
So maybe.
But we're at the point in 2020 that it's time to fund it. And I don't know who else we could go to get that funding other than you, senators.
Thank you. I just want to say I know that the 11 million out of the 57 million that's needed is for those two upgrades, and I think if that is the most crucial thing is how can we adapt, improvise, and overcome, and what are we going to sacrifice on what's already given if we have to look at that funding. So I'm not going to leave any stone unturned, so I'm thinking if there's any additional grants that we can look for out there, then let's look at if we have to do collaborations and work with the tri-unit to help augment that. I want to be able to look at that also and just know that
And
see
Speaker,
there's
I don't want to sound like a broken record, but all of the grants and all of the federal funding, and there are many programs available to us, they require one thing: data. So we require the technology to get that data for them. We will qualify. There are many programs that we can access money, but if we don't have the data collection and the robust system, we have to make that investment so that we can open up the doors that are out there. But it's hard to go to, the Gates Foundation if I don't know what our population suffers from, other than, yes, I know 10 people that have colon cancer today. But that's what an electronic medical records does for you, is it counts everybody. And if it's connected to public health and it's connected to all the facilities we have, it counts everybody on the island. And that's what we need to do. That's where healthcare is going. And it's a mandated infrastructure investment. I don't know any way around it other than saying, we'll just keep doing what we're doing.
Thank you, Mr. Chair.
Ms. Posadas, I just got to, before I pass on to the oversight chair, I'm going to assume that the hospital have sought, like you mentioned, a source of funding from the federal government. What would it cost to build a brand new hospital so they can fix a lot of the problems you have? And the only reason I ask this question because you're asking to fix a roof that's going to end up breaking again in less than 10 years from now. I'm going to bet on that, just the way the construction is. That building's over 40 years old, okay? I know that. Some of the senators weren't there yet, but I remember going there before it became GMH. But I'm only concerned that every time you keep repairing GMH, it's not going to get any better. And I'm just concerned is that I haven't heard, I was looking at that, there was a couple of the senators were looking at that last year, is trying to figure out a way how to get the federal government to help build a brand new hospital, start clean, all new equipment, find a way to fund it. But I'm just curious, have you guys looked at that? I mean, it's far-fetched, but you're asking $61 million. We're trying to get $30 million passed to get a bond for the landfill. That's half of what you need. And we're not going to give the landfill up either because there's receivership. But there are other areas that everybody's screaming for money. And I'm just trying to make it very clear is that if you found a source, maybe that's, like you said, you've come to us. We want to be able to reach out and help you somehow. But 61 is just, woo.
Thank you
Ms.
for
Posadas.
thank you for bringing that up. We have been in discussions, and we are talking about it, as far as looking at a new facility, because we really do need one. I've reached out to Rear Admiral Louis Tripoli. I met him at the PIHOA conference in Palau, and I have asked him if he can help us out with regards to getting the Army Corps of Engineering, at least get that started, to come and assess the facility and see how the structure is, and maybe they can make a determination and say, you know what, you need a new facility. You might as well just build a new facility. In terms of cost, I don't have one right now, but I'm waiting for the response from from Rear Admiral Louis Tripoli. The governor also is off island, and I have discussed it with her, and she will bring it to Congress as far as the feasibility and looking into the option of building a new facility.
All right, thank you, because I'm going to bet that Army Corps is going to tell you exactly what they told JFK. When they closed JFK, they said you got 10 years, otherwise it's going to shut down. It's shut down completely, and it's a brand new JFK. So, Senator Terlai, the oversight chair, or Senator Amanda, you want to ask, please?
Thank you, Mr. Chair. Thank you to the oversight for yielding. Just a couple questions. I really appreciate all of the different projects under the capital improvement budget, and I understand that all of these are really a priority for the hospital. Everything from the littlest thing at $1,500 to the biggest thing at $21 million. But you've only highlighted 3 as urgent and top priorities. So if we were going to have to cut this down some more, if it was needed, what would you highlight as other top priorities? Because there are over 100 projects here. Is that something that you can provide to the committee, or are you ready to discuss that now?
Well, I think the 11 million is ready to go projects. I
Okay.
think the roof and the electrical panel have been in discussions for long enough. They probably already have the A&E done. They're just waiting for, hey, can we send an RFP? Do we have the funding for it? And again, that's the visible thing. If you come to the hospital, you'll see the rain. If you
Yes, I'm familiar with the
so
bed sheets.
so I think so those are and the electrical panel, we don't know. It's still working. Obviously, we still have power, but it's 25 or 30 years beyond its normal lifespan. So it's like the JFK guy, 10 years too late, right? So it can be shut down at any time. I think the electronic medical record comes up pretty high up there. Again, I think in our healthcare committee meeting, it's not like I call up the company and say I want the system, and they say, okay, write me a check for 20 million. I mean, it's over time, but there is an upfront commitment of some amount, and the reason we put that 20 million is because that was what was quoted to replace the system with the Cerner system, which is what the Navy hospital uses, and it's what we have in our lab. But we had a discussion, actually Dr. Uggan had discussions today with Allscripts, and they're the EMR that's over at GRMC. So we're exploring, that might be a less expensive thing. The professor or the guy over at the University of Hawaii who runs the system that public health has, and he's kind of the Western Pacific expert on healthcare information systems. They train people who go into healthcare informatics. So he's very familiar with the system that public health has, and their same system runs the VA hospitals in the States and the Indian Health Service. So it's very applicable to our community. So we're exploring different systems, and obviously we want to get a grant or it to be affordable, but the 20 million is what these systems cost, so that's where that, and everything else is The HVAC system, again, it's upgrading, because if we start construction tomorrow on our family birthing center, we're going to need upgrades on the HVAC system. The HVAC system in a tropical climate, as you know, if you just go look at your houses, for you that are young that have a house but if you go to your mom's house or your grandparents' house that it's been around, all those ducts, it has moisture. The hospital infection control person is very careful, and the facilities guys are incredible that they've been able to keep all of those systems safe at the moment. But that, I think, is also probably up there in a priority in terms of patient safety.
Okay. All right. Thank you for that.
If I may, I'd like to say something on the needs for the capital improvement projects. When we first started this budget process, we met with all the departments that submitted their requests, and it was at $118 million. So we met with them over a course of 2 days and went through each item that they were requesting, and keeping in mind that resource is very scarce, we cut it down to 57 million, but not just because we identified the most urgent, which is the EHR of 22 plus the electrical panel and the roof. The other needs are also just as important and as critical. So we wanted to share that with you, that we did go through with each division and have them express their needs, and we cut back. So we hope that you can consider that.
Okay. Thank you very much. And then I know there was a recent OPA audit for the hospital that gave several recommendations on collections and how to improve so that we can get as much money back into the hospital as possible. And something that we spoke about in a previous hearing was collections, sending the delinquent bills to collections, and I just wondered if you had any update on that.
Oh, absolutely. Thank you for bringing that up. We secured the services of the Attorney General's office with the collections, and really it has helped because it has increased the collection up to about 35%. So we're getting, people are coming in to pay. In 1 week, we received payment of like $60,000. I mean, that's kind of like a record, because we normally don't see $60,000, from self-payers. But it really has helped the Attorney General's office collection, and it's not costing us any, because we didn't bid it out to a contractor. It's government service from the Attorney General's office.
Okay, that's a great update. And then also, I know the OPA recommended training for collection staff and supervisor, and I was wondering if that had been done yet?
Okay. The training, we haven't yet. We're still recruiting, also some resources for that.
Yeah, we just recently hired some more accounting technicians, because we're really, I know you guys don't like to hear this, but we are short-staffed in the billing and collection. We haven't really been hiring there, and we are in the process of training them, providing training in billing, and also we have placed someone in there to oversee the business office that is focusing on the collection piece. And we've seen, especially like on the self-pay, the collection to date has surpassed the collection of self-pay in 2018. So we have seen improvements, and with partnering with the AG's office is really helping.
Okay, thank you very much, and thank you to all of you on the panel for your time. I know how busy you are, and I wish you all a happy hospital week, so thank you very much.
Thank you, Senator Amanda. Senator Therese Terlai, Oversight Chair. Ma'am.
Thank you very much, Mr. Chairman. Thank you for your presentation, and if I could just go back to the overview again. So your page 1, and for those who are listening, so the hospital is requesting a total FY 2020 budget of $190 million. they have identified 133.9 for operating and 57 million for capital improvement. The hospital has also identified that from its own operating revenue, it will bring in $104 million. So they are asking for appropriations of 25 million from the Pharmaceutical Fund, the Healthy Futures Fund, and the Limited Gaming Fund. And this is, why compare that 25.8 million to the 30 million that was appropriated last year from Pharmaceutical Fund, Healthy Futures Fund, and the General Fund, right? So this is a little bit less than that, but a lot more. They requested also last year for capital improvement, but none was given. So this year they're requesting this 57 million. But none of the so just to clarify, none of the capital improvement is going to be paid out of the appropriations that you've listed here. In other words, the Pharmaceutical Fund, Healthy Futures Fund, Limited Gaming Fund, or
That's
your
just for
operating
operations.
revenue.
That's just for operations.
Okay. And so, all right. Okay. And so out of the 57 million in capital improvement projects, you've identified your priorities. Thank you for that. That's very helpful. So we can put our head around this 26 million for the data, the electronic health record system, 26 million. And then 6 million for the electrical panel, 5 million for the roof. So those are like very concrete things that we can think about. But there are, in addition to those and you've given us a priority list, and again, thank you for that, of capital improvement projects that will take us up to 57 million, pretty much. And these, you're saying, according to your departments, are pretty much the priority. And these 3 urgent items have to be done. As to the electronic health record system, that 26 million is a huge item for us. How soon do you think you will be able to make a decision?
Well, again, I think with the electronic medical record that we currently have, basically the clinical support is going to sunset by the end of 2020. I think we need to hire expertise to design a system for us, because that has been the problem. We don't have locally expertise in designing a system for our hospital our size. So this is why we are asking the health informatics person from Hawaii, that's what he does. He's a professor of health informatics.
Yes.
His staff designs systems for people like us. And again, I think the mistake in the past is that people sell us stuff all the time, and we don't do our homework, and then when we get it, it isn't what we need, or we only got some parts of it, but we didn't get the software for the stuff that we really want to use. So I think, again, that extra few million is to make sure that we do those appropriate studies and get a system that's designed specifically for our needs.
So I know you want to convert by December 2020, hopefully, to have support.
Can I
Yes.
make a point of clarification on that? When we had the phone conference with Cantata, which is our current EHR provider, they didn't give specific date of when they're going to sunset. It could be the end of 2020. It could be much sooner than that. So, we really need to address this at this budget cycle, because we have to start engaging consultants out there to assist GMH in determining the best system that would work for GMH.
But Ms. Benita, let me just give you fair warning. Get us a date. Don't come in and assume that we're going to jump out in the fire and says, we're going out there and we're going to catch the wolf. There's a wolf. No, there's no wolves. come of a date, then the oversight chair will let us know, then we work it from there, okay? Let's not assume anything.
I mean,
don't want,
with all due respect, Senator, we were not provided a date when they called us. They surprised us. Yes,
No, I mean,
yeah.
okay, so that's them. But for
Yes.
us, I guess I'm asking, because at our last meeting, we talked about, we're going to talk to Hawaii, they're experts, and we're going to see, and we're going to look at the other systems. So you've been actively doing that. So I guess I'm just
Yes.
looking at, is this a 1-month process, or we're talking about half a year to figure it out, design a
Yes,
system, decide?
Dr. Okamura in Hawaii said this is going to be a year-long
A
project.
year long?
Right.
Okay. All right, that's helpful. Okay. And all right, what about DOC? So does your operating expenditures projections here cover the DOC portion of your budget? Because you have a couple pages on DOC, but I don't see it in the summary on the front page.
Yeah, we didn't add that there. We figured that, that should be a separate appropriation. We're identifying GMH operation. But we did include the needs for DOC.
DOC.
Yes.
What is that amount? That's
It's over 2 million. There is
okay. And last year, did it come to GMH directly, or did it go to DOC?
pardon me?
Last year, did the money go to DOC and DOC's
in
budget, or
20
did it come to GMH directly?
It went to DOC, and then we send them the bill, and then they pay us. But if you will recall, Senator, in 2018, GMH was not fully compensated for the DOC operation. We were only paid for one quarter, which is around 500-some thousand, and the operation for DOC is over $2 million. So we're still waiting to get paid.
For
from
2018?
DOC, for 2018.
But what about 2019?
For 2019, we already received one quarter. So,
Are you up to date?
no, not.
I think
yeah.
if that's an issue, then please put that in writing. We need to take care of that before the end of the fiscal year. You don't want to wait on it. So let's see what's going on with that, especially if you're saying the money was appropriated to DOC.
Yes, and when you are deliberating with the DOC budget, if you could also address the inpatient billing, that's over $2 million.
So put that in writing, like a report to us, so we can follow up, and we will.
I will.
And what about, it looks like, under miscellaneous, there's an increase. There was appropriation under miscellaneous operations of $601,000 in FY19, but the FY20 budget has an estimate of $4 million. And can you just explain that?
The FY20?
Yes, it went from 601 to 4 million request.
Yes, I'm glad you asked that question, because that's where we put the incentive pay for the nurses, that 16% that we're trying to address, so that we can hire and recruit and retain nurses. So we put it in that line item. We have a unique budget software that we didn't want to create another code until, so we put it in there.
So this is to cover 16% incentive pay for nurses,
Yes,
RNs and LPNs.
that's
16%.
That's
Effective,
correct.
when did it begin?
It hasn't started
We
yet.
haven't.
yeah.
So this is for FY20?
Yes.
20? You've promised the nurses to pay them this?
We informed them that it was approved at the BOT-HR subcommittee. It hasn't yet gone up to the regular board because they haven't met. We're meeting this Thursday. We'll see what the decision is of the BOT. But they haven't gotten paid the 16% because it hasn't yet been approved.
All right.
And this is just a differential pay
Yes.
for when they work.
Okay.
Only when they work. If they're on vacation, on leave, they don't get that 16% differential
And
pay.
you think this will help you to increase the recruitment for example, the ICU nurses?
That's
To
what
increase our use of the beds?
That is the intention, but it's still, 16% is still under.
Okay.
It's not reaching the national level, but at least it's something
All right,
that
so.
we can offer.
But it's a significant increase, $4 million. So was there how did you cover this with your operations, your current operations? Did you decrease other items? I know, I see small decreases. but-
This is for 2020.
we're not covering
We-
it right
We haven't paid it out yet.
No, I know, but, so in your projections, your new operating budget isn't that different than last year's operating budget,
It's,
right?
it's,
Let me
it's
see.
just a
It's-
nominal increase.
Yeah, it's very
yes,
nominal, from
yes.
96 to 104, something like that? But, all right,
That's
I
the
guess,
revenue.
okay, I'm going to move on to my next question. So the rebasing rates, the new rebasing rates are reflected in this budget?
That's correct.
So your operating revenue, you've already calculated for the
Yes.
rebasing that you're expecting? Okay.
Yes.
Are you expecting additional rebasing? Or are we pretty much caught up now, or not?
Well, we are working on additional requests for 2014 to 2018, an additional adjustment, and this is to cover the rebase cost of discharge to the actual cost of discharge. There's still a gap there that we're trying to
Okay.
pursue. We have not determined that amount yet, and as you know how Medicare works, it takes a while. We can get an approval from Noridian, the CMS contractor, but it could take a year, 2 years before we see
All
the
right.
money. It's just a matter of being very, I guess, persistent and keep asking
Okay,
Medicare.
so
Yes.
besides that request, everything else is already anticipated in this operating revenue?
Yes, that's correct.
expectancy. All right.
Thank you.
What about, they asked about the billing and collections, and Dr. Berdali, earlier you said about the health insurance that we are pretty much collecting what we are owed from health insurance companies?
Yes, I think it's very little that's disputed, and other than sometimes being a little late or, and again, we need to improve our systems from the very beginning. It's tracking patients every day. So we bill and we collect retrospectively, right? So when you come to the hospital and you receive the service, yeah, a month from now, when the biller and collector, or a biller is looking at your bill and trying to get all the charges in there, you might get a bill, and then the insurance company might look at it and adjust it based on a lack of documentation. So we want to invest in utilization and billers to be on the floor and track the patient daily so that we know if the documentation doesn't support the bill, that the doctor is called to document. And again, it should be a real time. Those are the improvements we need to make that will help decrease that denial rate.
Okay. And so are those covered in the operating budget, or are those, you're saying those improvements that utilization
Well, those
people on the floor?
those positions are there. Some of them are vacant, so we're just trying to bring people in and train them to
Okay.
do that.
Okay, great. And there was supposed to be a new contract with the insurance companies, is that done?
So we're in negotiations
Still
right
in.
now.
Yeah, so I do want to qualify a statement earlier that, generally about 75% of the insurance companies do pay, and we do have some from time to time issues with certain provider, and we try to bring them in and demand that they pay. Otherwise, if they don't pay, then the option would be they're going to be out of network. So we have, did notify certain providers that if you don't pay up, then we're not going to sign a new contract. One of the reasons why we decided to terminate the 2016 payer agreement is to strengthen GMH's position in reducing denials and clarifying our position that these are covered benefits that you have to pay. And so we've met with all 4 providers already, and we will be finalizing the agreement that will be sent out to all the providers, and it's just one template that would be, it's a uniform agreement that all providers will have to sign. So we don't have like a separate agreement for one and another one for the other. And another thing is I wanted to bring your attention to this slide because Dr. Bardallo just kind of skimmed over it. And when you look at the slide where it says revenues, expenses, and patient census, if you look from, from 2011 forward to 2018, and look at the decline, the green bar, the decline in the census, but then you look at the revenue that GMH has been able to maintain its revenue despite the decline in census, which was expected, and that's because of the aggressive billing and collection, and also identifying the different service areas to ensure that we do maximize billing for revenues that are services that are provided to GMH. So there has been, marked improvement at GMH in terms of its realization of revenues. So I think this is a very telling slide on GMH's operations.
All right, thank you. We heard the update on the maternity warrant, but can we just clarify the A&E, is it out for a bid or not yet?
We're still waiting for the new and certified plan, A&E, from our RIM contractor.
Oh, so you have
as
that.
soon as we get
Okay.
that.
How long, when do you expect that? Because last time you
Well-
told us it might be completed in May.
Well, we're waiting for it. We
Any day
submitted
now,
the
like
payment.
that?
Yeah, any day now.
Okay,
We
great.
submitted the payment, and so we're just waiting for a RIM contractor to send us the updated and certified A&E.
Okay, great. And then the 600,000 appropriated in FY19 for the loan payment for the maternity ward, what happened to that funding?
Well, it comes to GMH as for operations. We get that on a monthly basis.
So you used it for operations?
Yeah, we're using it. We're receiving that every month.
I believe we did purchase, though, some furniture, because from...
Yes, that's from the Compact Impact money, that the $3 million that had been set aside for the Family Birth Center. So a lot of the equipment, we can't wait until the Family Birth Center is completed. So we have to start purchasing beds, and we've recently purchased like 4 birthing beds, so that when, your daughter or your in-laws come to deliver,
Okay.
they're going to use the new bed.
All right. I'm sorry, but I'm just going to go a little bit back on the nurses. If you get your full operating budget, you're going to be able to increase the beds in the ICU from 6 to what, 14, hopefully?
Again, let me emphasize that these nurses that we need, they need to be experienced ICU nurses. And if not, we're going to need to make sure they go through the critical care training so that their skill sets and their critical thinking skills are up to date. And so we just want to make sure that these are nurses that we're going to get are experienced ICU nurses. And Dr. Agan.
Half a day.
Half a day.
The 16% differential pay is for all of our nurses, because although the ICU is at a critical shortage, because it's the main unit that we use traveler nurses for in addition to the emergency room, the entire hospital is short nursing staff. And so currently, majority of our travelers are within the ICU and the emergency room. We do have one in interventional radiology. We spend about $1 million, or have spent at least $1 million. So we spend about, for every one nurse that we could maintain or bring in, we pay the traveling company for 4. So, or basically we could pay for 4 nurses with every 1 traveler. And so it's not just for the ICU, although the critical need is within the ICU as well as the emergency room. It's for all of our different areas in our nursing departments.
So Doc, could you just clarify that increasing across the board for all nurses, this by 16%, is going to bring you more nurses for ICU?
Bring in more nurses for ICU as well as the rest of the hospital.
Becau-
And hoping to maintain or retain the nurses that we currently have. Yes.
All right. Might this increase also the beds being utilized at SNU? So you said you're only using 20 out of the 40 beds possible?
Yes.
All right. Okay, well, that's good. I hope that works out the way you're anticipating. And the HVAC, Dr. Bradley, that you keep talking about, there's an HVAC listed in the capital budget that's $500,000. Is that what you mean? Okay. And have you heard any other discussion or proposals as to how we can fund this capital improvement part of the budget? I know in the last 2 years, they wanted a dedicated funding source to fund these things, but recently, has there been any discussion, anything else? Any of you? None? All right, just making sure. Thank you, Mr. Chair.
Thank you, Senator Ruiz. Going back to the nurses, 16% increase in pay? It's an increase in pay. We can call it differential, whatever.
It's
an
because it's
increase
only
in
when
pay.
they work.
Huh?
It's only when they work.
Right, but I'm just concerned is that if you remember a while back when they did all these nursing pay
Salaries.
adjustment,
Right.
we got nurses all over the place.
Correct.
And you guys are where it's hurting.
We are what?
You're the agency that's hurting for nurses.
Yes.
Well, everywhere else have a good group of nurses, and they're getting the nursing pay. And I'm just concerned has there been any mechanism somehow where some of them can start rotating into GMH? I mean, if they're going to get the nursing pay wherever they're at, I'm not trying to lead to DOE, even though that's where there's a bulk, but I'm just concerned is that and I just bring this up. Okay, already the oversight is saying, no, I'm only GMH. I'm only concerned about that. I just don't want it to somehow, some way, leak over to the other group, because that you guys have the shortage.
Well,
And I'm in support of that, okay? I'm in support of GMH getting as much help as possible. My parents go up there. I have my sisters, my siblings. I may end up going up there, even though I'm active duty military retired. But I'm just concerned is that I just want to make sure that we're going to take care of the folks that are, because you're burning out. You're burning out nurses. I know that. I've ran into several of them, okay? And you give them extra pay, but if you don't get additional nurses, the same folks are still going to burn out. And I'm just concerned about that. And I just wanted to ask that question.
Well, Chairman, I think some of the difficulty, there's been several difficulties. One is with the opening of GRMC, the overall cost went up. So I think it's just to remain competitive.
Okay.
The reason we're trying to call it a differential is that differentials traditionally, it's like hazardous pay. So it doesn't apply across the GovGuam pay scale. So I think back in several years ago, anytime somebody raised nurses' salaries, the school nurses got raises, every nurse in the whole wide government system, even if they were working for some other place, got the same raise. So that's why we're calling it a differential. If you're willing to work in a 24-hour facility called GMH, you get the 16%. If you're going to work at the school, you don't get it. But that requires not so much us, but the fortitude of those of you who pass these raises, because as soon as the school nurses started yelling, they got bumped up on the system as well. And the 16% is it actually came about because we were trying to recruit nurses from the Philippines, and the visa that we were trying to get them under, when we did the wage study, we were way below even what nurses from the Philippines were expecting to make. And when we raised it 16%, that's how the 16% came in. we found out that didn't even meet their requirements either. But again, it's hard to come here and ask you for 61 million, much so 16%, that's where that number came from. But it's really trying to attract our nurses back from the other facilities and to remain competitive with the other work sites that they have options to go to.
Okay. No. And when you're talking about the funding, and you remember the oversight brought up, you asked for 30 million last year, you're asking for 25 this year. There's the 4 million. Okay? That's what I'm eyeing. I'm looking out. I just wanted to make sure that we just have to get my staff to make sure when we write the budget, it's very specific to just you folks, if that's how the body would want to go in that direction, okay?
And I just want to include that the 16% still puts our nurses at GMH in an acute care setting under the national average, still under the national average.
So you need more.
Yes.
Ask it next year. No, I'm
Next
just
year.
kidding. My question would be, other than that one, I don't know if any of my colleagues asked that. Maybe the speaker did. The $11 million that came in on rebase, was that asked earlier?
No, I was waiting for you to
You're
ask.
waiting for that. You knew I was gonna ask you that.
I was expecting that.
You received $11 million
Yes.
in addition to what the budget that you approved for 2019. In 2019. How come you
Yes.
didn't fix the electronic and the, what did you use the money for?
Tinaw, Senator,
Tinaw? Tawag na
tinaw
na,
sa
gabi.
untong nga na tinaw. Sa 2018 na tinaw manainya spitat. 2017 tinaw pusgwaji mafananan na accounts payable.
Okay.
Iti 11 milyon na.
Okay.
Pa na sedbiji pa benaposiji di binispitat siya na
Okay.
manananga siya vendor.
Fino English, wala ba natin makomprendo? Try that one more time, Ms. Manglona. One more time.
So
There you go,
what,
Doc.
yeah, so what happens is we have had this same shortfall forever.
Yes.
And so this $11 million windfall, even though we were fully funded for operations for fiscal year 2018, it didn't make up at all for the shortfall for the last 10 years. And previously, the way that the government has, when our accounts payable rises to such a high level that somebody complains, we either take a loan out, we get bond proceeds, we get a specific legislative, and we haven't had one in several years, so that 11 million was spent years ago. And I think back to how we survive without a capital improvement budget for the last 10 years, we buy supplies. We buy these things. We buy it out of our operations budget. But who suffers that? Well, the employees suffer because they don't get any help because we don't hire because we spent the money on equipment. We are still open. We are still expanding our services, and that money comes from operations. The vendors are the ones who suffer because we delay their payments. I mean, it's a cash flow thing, so it's not as if we didn't make any capital expenditures over the last 10 years. We spend. We buy supplies, we buy equipment, the operating room functions. We bought and fortunately the volunteers buy us equipment every year as well. And now we're like, we even ask them to buy us, like, before it was, can you buy us some supplies? Now it's $200,000. It's, thank God Joyce is on top of there. So they're now buying us major equipment. So I think that's where all these rebasements go to. As soon as the money comes in, it goes to pay down accounts payable from years before, not just from 2018.
So how bad are you on your accounts payable? I'm hoping you dump all 11 million there, if at least close to it.
We are managing our payables, it's around $15 million, but, you know, we work with our vendors and, you know, we try to pay it down as cash comes in.
But the 11 million, Benita, how much did you use to pay?
It's, cash comes in,
No, the 11 million, that was cash, that was, if I'm correct.
I understand,
Yeah.
you know, each payroll is like 3 million, over 3 million, just one
Okay,
payroll.
I mean, just be clear.
so that's
11
like-
you got, you use 3 here, and you use,
Oh, no,
and I
sir.
understand
We
it,
use
just
it
say
all.
it. Just
Yeah.
say what
Yeah.
you use it for, because that's what
It's
the
for
people wants to
operations,
know
yeah.
is, you got 11 million, where did you use it for?
We paid vendors and we paid payroll.
Okay.
Yes.
And how are you doing in your allotments from your boss?
Yeah,
Ms.
we're
Posada?
getting, we work well with Ed, and
With the
you know,
governor's office?
every other week, he gets a call from me. to-
But how is the allotment coming?
It's
Is it-
coming.
Is it meeting your payroll and hopefully some of your supplies at least?
You haven't heard any payless payday, you know?
Well, I'm not worried about the payless payday because you haven't heard it, but I'm just worried that, like I said, I have relatives, I go to GMH.
Yes.
If I don't find the supplies there, then I'm going to come knocking at her door and your door and saying, I thought we had this discussion.
Yeah, we.
You know, just the basic, maybe you don't have the computer system, but at least put favor, when somebody needs a napkin or needs a Band-Aid, put it on. I mean, there's going to be times where it's going to be tight, but I'm just saying,
It's always been tight, but we try to manage, and if you know, it's just recently that we got that money, so that has really helped our cash flow and
Okay.
and put some, you know, faith and trust with the vendors. So it's like, okay, they're giving us supplies now because they know that money came in. So, and then prospectively, you know, because of the rebasing, we'll see more increase in revenues.
okay.
I think our
Yes,
vendors
Doc.
read the paper too, so.
read the paper
As
too,
soon
huh?
as this hearing, when they find out we got 11 million, I get 8 emails from all the,
I get text messages for payments all
Okay.
the time, so.
Does Guam Memorial have insurance? You have
Yes,
insurance for your building and everything?
yes.
So how much did you get from the insurance to repair your cracked ceiling? Your roof?
Nothing.
Why not?
Because we didn't meet the, you know, there's a threshold on, what do you call that?
The deductible?
Deductible.
Really?
1 million,
1 million?
nitinaw.
What did you say it
You know,
gonna
when we had
cost?
that typhoon, we had to, we did,
No, but
claim.
you identified the cost is what, 4 million, was it?
no,
5 million?
for,
For your roof. You got 6 million for your electrical and then.
no, but you're talking about the insurance, right?
Yeah, no, your deductible, you said is 1 million. I
The-
mean,
the deductible.
We have to understand, and we
Yes.
all know this in Guam, there's earthquakes every day.
Yes,
The insurance people are praying nobody's going to knock on their door every day. But GMH have a bunch of cracks. You've got roof leaks. You've got a bunch of problems up there. And how come you're not knocking on the door and saying, I think we exceeded the $1 million. Can you start repairing? I mean, we're just trying to find a source. Because I know you guys go after them to pay for your patients.
I
So you should be going after them because you're now their patient. So I'm just curious. You haven't knocked yet, right? So I know
think
you're gonna be knocking soon,
the-
right?
No, I mean, you know, that would be the facilities to determine if there's a million.
I will let Mr. Kandu know as soon as he comes back
Yes.
to check that out,
Yes.
if
Because when,
that's
you,
covered by insurance.
because when you call the insurance, they send their adjusters. It's not you guys determining if it's related to typhoon or earthquake. It's them. Okay? Let them
Yes.
work it. My colleagues earlier asked a bunch of questions. They kind of filled most of it. So I'm going to ask, let me see, some of them. Yes, I'm going to ask Senator Munya, and then I'll work to my right before I go to Senator Kelly March, who's typing away on her laptop.
Thank you, Mr. Chair. Yeah, I know unfortunately we want to devote the entire afternoon to GMH, but some of us, we have to juggle a few things. So thank you, Mr. Chair, for giving me the opportunity. Dr. Berdalio, I know you mentioned something about how important data collection is. And so this question is basically, do you have accurate data on billings for migrants from the freely associated states? And what efforts are being made to use this data to justify more federal grants or funding?
We do collect the data on the citizens, and we do submit that
I'm
on
sorry.
an annual. We do collect the data on those citizens, and we submit that to the Bureau of Plan and Statistics.
Okay,
Mr. Kando in planning has used some of that data, and he just recently wrote a grant. So I don't know exactly the details of that grant, but we do collect the data and we do use it.
okay, okay. And then I'm curious if the demand for beds has gone down since GRMC has been operating, or no?
The demands are, I would say they're going up, because even with GRMC existing, we are the only outlet for the mothers and pediatric patients. And with our nursing shortage, it limits the amount of beds that are actually available
For the maternity,
for the entire hospital.
for the entire hospital?
Yes.
Okay,
Yeah, I
and
don't think together with GRMC, I don't think we meet the recommended bed count for our
Pure-
population
for both-
together.
for both
That's
hospitals.
correct.
Yes, as a matter
So
of
we're
fact.
constantly,
Yeah.
So then basically GRMC is just alleviating some of the pain that GMH has been carrying.
Can you imagine? Yeah.
Just not,
Yeah.
but not necessarily helping it, just alleviating some of the stresses of the patient care.
well, I think again, it's additive, right? So they're taking quite a few government patients as well. They're in a community that's underserved up in Dedido. There's a large population there that goes to their hospital and also can't pay, or are also covered by Medicaid and MIP. So I think they are helping, but helping, I'm not sure what you mean by that, but in terms of you don't have to lie on the floor when you come to the hospital, 'cause-
Right.
Or sit in the hallway,
Right.
and
kinda-
even then you do
Still.
in the ER for both places.
Still.
Yes.
Okay, well, that was my question, is because I
Yes.
know a lot of patients are usually waiting, around for beds, and so I mean, just imagine, just an average person just thinking, oh, okay, so this should help GMH, now that we have this other hospital. So that was my question, really.
They
Has
also
it-
have their own struggle with nursing shortage, and so, but the demand for patient beds are really more in the cardiac care, like telemetry and ICU. Those are really where we see the demands for patient beds.
Okay.
So I just want to mention something that, before GRMC opened, GMH, remember on the PDN, the red?
They used to have
So our occupancy was, over 84% average. And now after GRMC opened, it's around 62. That number is climbing up again. And the average occupancy for a hospital our size is about 58%. So when you're looking at the staffing back then, when we were about 80-some%, that was not normal. That was when the nurses were burning out.
Okay.
So
Okay. Just thought I'd throw out that question and see, hopefully, I was hoping for a better answer, but I guess not. And also, are there any issues with prompt payments from like health insurance companies? If so, what are they?
Well, again, I think, insurance communication, I think the way around that is utilization review, getting our bills to be cleaner because we're following the patients every day and documenting what we're doing. So when those bills go out and the insurance company they have their own team who scrubs the bill and decides what services are covered, what are not, and then it comes back to us. So I think in terms of clean bills, we have fairly good relationships with most of the insurance companies.
Okay.
But there's always, the economy here in a small community, it goes up and down, and it goes up and down for everybody. So I don't know.
Including insurance company payments?
I think so. I think so. It's hard as the only hospital to say, sorry, we're not accepting your patients anymore, or we're accepting them and they'll become self-pay patients. I think I was talking to the Senator Sabina Perez yesterday about my feeling about collections and tax garnishments of patients that are poor. Bankruptcy is, 25% of bankruptcies are caused by medical bills. And here you have a population of patients who may not be able to afford to pay, and we're going to spend a lot of effort trying to go and collect from them, and then we're going to garnish their tax refund that they're entitled to because they have an earned income tax credit. And these are not patients that have bank accounts that can put savings away. And this tax refund might be the only access they have for some breathing room when it comes sometime in the future.
Right.
That's their savings account. You and I put a little money away maybe regularly, and we can access it anytime we want. But people who don't have any resources, they may be counting on that tax refund
For other things.
to meet some basic needs, yet we're going and collecting from them and garnishing them without understanding their circumstances, just because we can. And I would say that we need to do a better job, even as healthcare providers, and as the hospital, to make sure our billing and our social workers and our collectors know what these people's financial circumstances are. Because I think it's unfair it's the same to me as turning them away and saying you can't come.
For as long as I can remember ever utilizing GMH, I always knew that if there was a bill, then, and I was going to get a tax refund, that I was not going to see it. It was going to go directly to GMH. So, you know, I always remember that. And finally, actually, this is just kind of on a lighter note, because one of my staff members is I don't know if you know this, but he's trying to log on to your website, and Google is kind of flagging it as infected. The irony of that, but. Maybe you might want to have someone in your tech check that and see.
Yeah. You can still log on. I think I've received that message also,
Right.
and
Yeah.
I just log on and it does log on. I don't know why my security at my office is the same way.
Oh, so it flags it.
Apparently some security systems flag it.
Okay. I was just wondering if that was maybe something on your end that could be fixed. But okay, thank you. Thank you so much. Thank you, Mr. Chair.
Thank you, Senator Luis. Senator Tello.
Thank you, Mr. Chair. Ladies, thank you so much. You're doing a great job there at GMH. I mean, and I want to apologize, be the first one to apologize for not giving you the money that you need. And I know that you've been asking for it and asking for it. So now, you know, it takes 8 of us to get you that money up here. And I know there's quite a few of us that really want to support GMH, and I'm one of them. So we're going to try to find some money for you, because it's needed, definitely needed. So I just have a few questions that I'd like to ask you, and greatly, again, I appreciate your time and being here. One of the things I noticed on your budget bill in the area of limited gaming funds, you have down here 600,000, correct? Okay. However, in the governor's budget, the executive budget, there's 0. Huh? No, this is the limited gaming fund. This is the limited gaming fund. According to the executive budget, the limited gaming fund that was provided for you is 0.
One of the reasons why I put that in there was I looked at the average collection of the limited gaming for the last couple of years, and I saw that the portion were allocated to 2 different areas. So I figured that at the minimum, you know, we get something every year, because there's a portion, there's a, you know, the law that requires that it go to urgent care. So at a minimum, I put in 600,000.
Which is absolutely right, Benitez.
Yes.
So I just wanted to make that clear to you as well. that's what the executive, and I know you work with the governor's office too as well
Yes.
when you're going through your budget. So please let her know that you need that money in limited gaming because it's by law, okay? Number one. Number two, have you ever gone after the Tourist Attraction Fund? The reason why I'm bringing this up, we have tourists who go to Guam Memorial Hospital all the time. In fact, it's important that we have a good hospital because I know that when I travel myself, I want to make sure that if anything ever happens, that there's a place I can go to in case I get sick while I'm there, or if I get in an accident, that there's a good facility that I can trust to be there. So I think the Tourist Attraction Fund is a great opportunity, and I'm going to lobby my fellow colleagues up here to try and find some money in the Tourist Attraction Fund because it goes hand in hand with the hospital and here. So that's one area that I'd like to look into. And once again, you said 11 million would be the roof and the electrical. Guess where I'm going to look for that money at?
Tourist Attraction Fund.
That's right. That's right.
And the EHR.
Now, the other one is DOC. I was quickly trying to write this down. That's another place we need to look for money there. And I just want everybody to know that money, no matter what you have, relationships, money, cars, houses, if you don't have your health, you have nothing. Nothing. So that's priority, I think. Now, DOC, you mentioned in 2018, only $500,000 was paid to you, while they still owed
They owe over 4 million because that includes the.
Let's just go to
inpatient.
2018. Let's just go to
Yes.
2018. How much in 2018?
It was close to 2 million.
2 million one?
Yes.
2.1?
Yes, something
okay.
like that.
In 2019, how much there in 2019? I'm sorry.
They have paid over 500, so we are working with them to pay the second quarter.
Okay, so
Yeah.
this 2019, they only paid
that's
out
only for the
500?
clinic. Pardon me? That's only for the clinic.
Yeah, that's only for, when the inmates come into the hospital, that's another fee
That's
of
another amount.
inpatient that we haven't
Okay.
That's
received any
separate.
payment.
I'd like very much if you can send me that amount total.
Yes.
But if you can break it out from 2018 to 2019, to break it out, not just a full amount, but just itemize the year and the cost on that. The other one I have here is, okay, we did the tourist attraction, we did that, limited gaming, retaining nurses. I think that's very good, differential pay, very justified in that perspective. And then my other colleague had to leave too soon, so the one that he wanted to know, we were talking about the rebasing of 11 million earlier.
Yes.
He was curious, as well as I am, how is that appropriated to the hospital to utilize to fund?
How is it appropriated?
Yeah, how does that work? Usually when any money comes in, it needs the legislature to appropriate. How did this work with the $11
This is
million
from the
rebasing?
federal government.
From the rebasing?
The rebasing is just
Federal?
Medicare's reimbursement.
Oh, federal.
So it's just
Federal.
it's federal government,
It's
it's
federal,
not an
Yeah,
appropriation,
yeah.
it's just
I'll let him
to
know.
meet the costs.
I see.
Yeah.
Yes.
Okay.
Yeah,
That's
it doesn't require
Yeah.
appropriation.
Okay, well, thank you so much. I've been studying your budget and looking at areas to actually help. We need to start stepping up, This is our only hospital, that people can go to, our public can go to. So, again, I appreciate your time, ladies. You did a great job today.
Thank
Thank
you.
you.
Thank you, Senator Tello. Yes, we need to step up. Senator,
By the
Senator
way,
Lee.
one
Yes,
other
ma'am.
thing, I just want to mention that I put out a Bill 5, that actually put the task force together. The good chairman actually mentioned that about building a new hospital. So hopefully we'll have a public hearing on that and hope to see you guys there. Okay, thank you.
You see, this is great. I got women in front of me and I got my colleagues, all women, but not a problem. As long as they keep acknowledging that I'm the chair, we're
And you're
good.
the only guy there.
But if you notice, if I have my colleagues with me and we vote yes, you may get lucky and get your budget. Okay, let's focus on trying to make sure we have enough money spread across. Senator Lee. Ma'am.
Sidus Masi, Mr. Chair, and we have our dream team of ladies down there and our dream team of ladies up here. So thank you very much for presenting this budget, and also just for representing all of the hardworking women and men, our healthcare professionals that are currently making it happen at our only public hospital. I know that much of the work that we are focusing on today, and a significant amount of this budget request, focuses on patient outcomes and patient care. And so one of the questions that I wanted to ask is, how does GMH consider feedback from the patient satisfaction surveys? I know you guys put that together and you receive them back from patients. If there is a pressing concern, is that addressed in your in-house trainings? Can you give me a little bit more feedback or provide the committee a little bit more insight on that process?
Absolutely, we take that very seriously. Maria Perez is our guest relations manager, and she's in charge of those patient satisfaction survey. She reports that as part of her QI every month, and if there are pressing issues such as patient complaints, she brings that over to our attention or even to risk management, and risk management will then investigate and look into those complaints to see if there is a need for an RCA or just further investigation, and how we can then resolve. We've just had about a few last week, and so we've reached some resolution on those complaints. But yes, we take those very seriously because, again, we want to improve on the services that we provide and make the patients feel that, they are treated with dignity and respect, and that they feel satisfied with the services that they receive.
Thank you very much, Mrs. Posadas. I wanted to ask about a specific project that's listed in your budget. What are GMH's plans for the Heart Project? I know that the FY2020 budget request shows about $350,000 for capital outlay, but it also shows that the current nurse and technician positions are vacant. So I just wanted to get a little bit more feedback from you on the Heart Project.
Well, it's we do have an outpatient cardiac clinic, and we do have a cardiologist who sees patients on an outpatient basis, and so that continues. We also have a cath lab, so if there is a patient that the doctor determines need to have a cath lab, that procedure then is scheduled in the cath lab.
Okay.
And so we provide that service. In terms of a more intense type of cardiac surgery, that's where our limitation is at. We haven't done, because it takes a team.
Right.
It really takes a team to do that cardiac thoracic surgery. And so Dr. Agustin can expand a little bit further on that one.
Thank you.
So the Heart Project, and you can see under professional services, there's a lot of lines that are missing. This was actually a lot bigger because as we speak, we have a interventional radiology suite that is shared with the cardiologist to do these cardiac caths. But because we were trying to only show a critical need for the entire hospital, a lot of those blank lines, although still exist and are still as important, were put to the side for other parts of the hospital's priorities. Ideally, we would like to have a cardiac cath lab that was separate from interventional radiology, because if you have two procedures that are emergencies trying to go at the same time, you can see the challenge that we face by only having one room. On top of that, again, it goes back to staffing and our shortage.
Thanks, Doc.
Okay.
I think I have a few more questions on the Heart Project, but I'll try to just maybe send you an email and try to open up a dialogue for additional questions on that. Ms. Manglotnia, you mentioned the aging, or you mentioned existing payables. Could you update us on the aging for existing payables?
Yes, it's about 10 million in the over 90 days. And
Anything beyond
total-
that?
No, that's over 90. And then, then you have the 30 to 60, the 30. So I can give you the exact number. It's about 15. It ranges,
15.15 or
15
50?
15 million.
15 million total,
Yes,
and then
yes.
for over 90 days is about 10 million?
Yes.
Okay. And what's the oldest?
It's
There-
over, we just classify it as over 90, but some are old. But, the vendors, we try to work with the vendors.
Okay. Thank you, Mr. Chair.
Ms. Posadas, provide us a report on all your payables. We want to know exactly what year and everything of who you owe. Okay, just provide that. We're going to need that information.
Sure, we'll do.
Senator Kelly Marsh, title, ma'am.
Sujus Masi, and thank you for coming here again. We've gotten to see you a few different times, and it's been very important. Each time that you come here, we are better informed about the progress that's going on and the ways that you are trying to handle the issues, and I think that has been very helpful and informative across the board. So it's been good to hear that you've been making progress on the new electronic health records system, that is moving along, and that there have been improvements in collecting revenue. So those are positives to be hearing about. In that vein, when you mentioned providing data about the compact impact calculations that you've been providing that to the Bureau of Statistics and Plans, does that mean that you have been working with that bureau to figure out the appropriate data collection about the patients, specifically for compact impact calculations? I know that the the Government Accountability Office out of the federal government has made statements about how that needs to be changed from the previous ways that we've calculated it. So I'm wondering if you've been able to have that dialogue and improve the data collection so that it meets the GAO requirements.
I just recently received that inquiry, and I just recently also received the report from planning. I haven't had a chance to look at it, but we certainly are willing to then make sure that if we need to change how we collect the data to make it more meaningful and more relevant, and certainly we'll look at that.
Maulik. So the one that's coming to mind, and I don't have a full handle on all of the changes that they're asking for, but just that difference in understanding the citizenship versus the ethnicity, in that making a difference in the calculation, whereas in some places, in some of our agencies, it's just been based on ethnicity, but they are saying that, as I understand it, but BSP is the one that will be able to fully tell you, but as I understand it, it needs to be determined by the citizenship in order for it to be a true impact in that way. But yeah.
I'll take a look at that
so
report.
it's good to hear, of course, that you're willing to and will be working on that. I'm sure that will improve the data that we're collecting and improve our ability to calculate, and hopefully the end result will be improving the collections that we can be getting from the federal government so that we're getting closer to a true cost of reimbursement.
Correct, right.
And you may not have any solid numbers about the improvements for the electronic health record system and how it will be helping you, but I'm just wondering if you have any general understandings, at least, as to how it may be helping us in the future. I want to look for a bright future, and so in the presentation, you were saying that this improved, new electronic health record system, that it will be able to provide improved calculations and in the revenues and expenses. It will be able to make you better able to qualify for grants because you'll have better data collection, and it will be able to improve billing. So do you have any general sense as to how that's going to help the health of the hospital overall?
Well, I think it's really using technology so for the compact impact, when a patient presents to our door, that's a data point. So it's not just ethnicity, it's citizenship. So those are data points. At the moment, I have to go open a paper chart if I didn't have EMR. And at 20,000, points a day, or a year, because we see 25,000 people in the ER, that's a lot of chart review. So again, I've been here for 25 years and I'm in the middle of conversion because we only had paper when I first moved here, and now I'm doing electronic medical records. But since I'm gathering the data for these types of sessions and I go to the people who are collecting the data, sometimes I have to ask 8 different people because half of them have it on a spreadsheet. The other half have to actually go to medical records and dig it out of paper because it's half in paper. So just the process it gets much better when we are fully electronic. But my use of a computer, just because I type it in, so some doctors are still, well, I type my note in there because my penmanship's really bad. So now the medical record person can read his note, but the computer can't count because it's not in the data. If you have to click the box for the computer to count it, the computer can't read the note. So some parts of it is the learning curve of converting from paper into, and then the ease of the medical record. So it gathers, for the 25,000 people who came to the ER, we can know why, we can know their complaint, we can know what tests they did. So when we have patients who go to GRMC with a stomach ache and they get a CAT scan and they don't like what the doctor told them, like, because you're good, just go home, you have a stomach ache, don't worry. But they'd get nervous, they're like, I don't believe that guy, so they come down to GMH. They don't tell us they went there, so they get another CAT scan at the cost of $900 or something like that. If they're self-pay, probably, I don't know, $9,000. No, not quite that bad, but so electronic tracking allows us to save money because a CAT scan 6 hours later for a stomach ache's probably not going to be any different. And why should the same person get it multiple times? And typically these are, again, it's one thing, insurance will cover the first one but won't cover the second one. And if you're the second hospital, too bad, you should have known they had it. But sometimes patients don't know. Multiple doctors and have had multiple tests. You can carry that with you on a thumb drive so that when you go to the next person or you're traveling, you have 3 renal transplant people, 1 cardiologist, because we will have enough data on the healthcare needs of our population. And that's the future of medicine. It's just in our future, I don't know when we're going to get there. Hospitals are already there, or are a year away from there, or 2 years away from there in the States. But we're still at the stage 2.5, and other 80% are at the 4, 5, 6, 7 level.
Well, now that my life is partly taking my mother to her medical appointments and seeing her through procedures, I can certainly see the benefit of that, because it's true, she has to be on top of her records, and we have to cart around a lot with us. So definitely can see improvements to our healthcare, and that's incredibly important for our entire community. And so what I'm hoping along with this, because it does sound like it's going to be providing better efficiency, better trackability, and other things that will be able to hopefully lower operational costs, that this will spell out to a significant difference for you. So that's, along with all the other benefits, that's part of what I'm hoping for. It's that there's going to be some significant improvement in the way that you can be generating revenue and lowering expenses potentially.
Thank you. Oh, you're going to answer?
Well, no, I just wanted to add to that. Currently, we use about 5 systems to look at one patient at GMH, which is very inefficient. So having a good EHR system will allow us to decrease the amount of time it takes to look at one patient, follow a patient from the emergency room through discharge, allow physicians to code the diagnosis upon admission. It will keep all of the medical, the history together with that patient every single time they come into our hospital. So it takes, it becomes a more efficient system for us overall. We won't have issues with interfacing because 2 of the 5 systems don't speak to each other. So yes, that's also what we'd like, and it would help us keep track of our quality assurance and develop performance improvement projects for us to improve safety in our hospital.
Okay. I got a simple question. We keep talking about the electronic computer system. Do you have any computers, hardware right now, system? You do, right? And it's old, it's new, isn't it? It's only 2016, correct? And was that the equipment you were mentioning, Doc, earlier, that it came but no software or something like that? Or
Well,
no?
the electronic health record we have now was bought in 2012, 11. And by the time we implemented it, meaning training,
Right.
bought the equipment for it to run on, and actually went live, meaning I, as a doctor, can come and sit down and actually use it. It was implemented in 2016. So again, it's really, we need
It
better.
got old real quick.
Well, it got old before we opened it. So again, if you look on the capital improvement budget, there's some $600,000, give or take, for our PAC system at the radiologists. And again, it's the same thing. We have these great machines, but if we don't get the updated software, by the time we buy the software, the machines...
Outdated. I understand.
Yes,
I
sir.
just, is there any way to turn it in, get credit for it? I mean, I just thought I asked the question. But anyway, my next question is, we talked about the TAF, the Tourist Attraction Fund. What is the percentage of tourists that enter the doors at GMH? And are they paying, or is it something you have to track them? Or is GVB paying for it? I'm only concerned because normally when we start tapping TAF, it's got to show that they're using you. And if the numbers are so small, we would just try not to tap. There are other agencies that need that funding.
I
Okay,
think,
I just wanted to ask you
I
if
think
you had that
generally
information.
if tourists come, they're typically emergencies. Most of us, when we go on vacation, don't want to go to the doctor. So it's the car accident, the hit by a thing, the medical problem that they didn't expect would. So they're usually the high-priced kinds of diseases, but I'm sure we can track that data if we had...
Okay, we're going to need that information. The new IT
we
system,
can
right?
go to the
But-
warehouse and get the charts out.
But I know that you don't have hundreds and hundreds. Okay, so Ms. Posadas, take care of that fund. Get the information, okay? Please, there's a lot of information we're going to need, okay? especially since your
try-
oversight also covers GVB, she's gonna be debating who should I
She's
make
gonna
sure gets
transfer
the
the
money,
money
okay?
from GVB.
Okay, Senator Sabina, and I know she's got a long list, but go for it, Senator. I'm just teasing.
Thank you, Mr. Chair. Actually, a lot of the questions have already been answered, and I just want to thank the panel for bringing the budget here today and actually even being frugal, because I appreciate the fact that you actually looked at your list and you pared it down. So I see that these funding projects are critical and they're long overdue. Just a question that Senator Pito and myself are interested in is as far as if you obtain the additional funding of, I believe, 61 million, how would that help us to get accredited, the hospital being accredited? Or what part of these projects would be responsive to the accreditation needs of GMH?
Is that, the priority really is the CMS, because we just got revisited. And so the CMS citation, the surveyors was just hounding and hounding at us as far as making sure what resources are we going to put into place, particularly with the QAPI program, because they recognize that, yes, we're doing data collection, but we're not really analyzing all that data to then take a look and see how we can improve our patient care services. And so that's one area where, in terms of if we get this funding and we have an updated and enhanced EMR, EHR, all that data will be more accurate and the documentation will be clean. And then also looking at our policies in place, training of more of the people that we employ, bringing in additional resources with that, with that skill set. All of that, it is going to help us towards, maintaining our CMS certification, and at the same time, then moving towards the direction of getting Joint Commission accreditation. Because a lot of the standards that Joint Commission has established are pretty much similar to CMS, but I think there are a lot more, there's a longer list of standards that Joint Commission has, but they're fairly similar in terms of quality, patient care, safe patient care. Those are some of the standards, patient care standards that they expect hospitals to adhere to. In a nutshell, I know there's more information about it in terms of the CMS conditions of participation and the JCO standards, but that is one of our goals, and we've we're also including the doctors to buy in to that goal of even maintaining our CMS certification and then moving towards the direction of getting Joint Commission accreditation.
Thank you.
Did that answer your question?
Yes, yeah, thank you. The other thing is the Affordable Care Act. So with this additional funding, would any of that funding, can that be utilized to do some matching for that, for Affordable Care Act? Or no? Am I just completely off with that one?
No, I think you're talking about Medicaid match, that would actually be public health.
Yeah, I think, this is a budget hearing. There's other things as far as how do we, create more affordable care, health care in our community and develop more cooperative health care. I think that's something, preventative care or even wellness. I think that's something that we probably could move towards in a different conversation. But so I think that's it for my questions. Thank you.
Thank you.
That's it. Thank you. The Oversight Chair now will ask the final question before I close it, but I just want to give you fair warning that I may call a roundtable if there's any additional questions we may need or answers from questions. Okay. Senator July.
Thank you so much, Mr. Chair. Thank you again for all your cooperation in answering all these questions. If I could just follow up with Senator Perez's question regarding Medicaid funding and matching. Part of that funding, I thought, could have been utilized for electronic data. And I'm not sure if that's ever been looked at for the hospital in specifically or not, or if it applies, I'm not sure either, but have you checked whether that's applicable?
Yes, there is some funding that Dr. Nakamura in Hawaii said that we might be able to access for, actually, I think for consulting some of these analysis and design programs, or to pay for some of these. So we might be able to access some Medicaid dollars for that.
Okay,
And
great.
that may be from the ACA, I don't know, yeah.
I remember talking to him also, and also to Linda DeNorsi, who's implemented it very successfully at the public health. So, and it was her opinion that, yeah, the two systems, GMH, public health, being in a compatible system would be very useful. But I'm not an expert on that, so I'll leave it to you. But could you also let me know, so the 25, in the governor's overall 2020 budget request, she did allocate 25 million for GMH. Is that, can you tell, is that from the same funding sources or different? Because one of the senators said limited gaming wasn't one of those funding sources.
19 point something million is coming from the pharmaceutical funds, and then another 5 point something million from the Healthy Future funds. So those are the sources that the governor allocated and identified in her 2020.
So what is, are we in using the limited gaming fund then, if we followed your proposal, which is to use a lot more limited gaming fund and maybe change these allocations a little? How does that impact the rest of the 2020 budget requests?
Well, the closer you get to the 87 from getting from other sources, that would be great. Because, you know, we did identify the $26 million that was from the governor's submission, but there's still a shortfall of $4 million for operations, and then you have the 57 for the capital improvement requirements for the hospital.
No, I mean, if we follow your proposal, which is to take some of the 600,000 from limited gaming, for example.
Yes.
Does that taking from another source that's been appropriated in this 2020 proposal?
I'm basing, as I had, I think it was Senator Tello that had mentioned, there is law that appropriates, you know, the limited gaming.
Yes.
Is earmarked for the urgent care. So that's why I, you know, looking at what we have received in the last couple of years, so, and then looking at what the governor had earmarked for like, I think the mayors, that's how I came up with about the 600,000 that.
So is that in this 2020 overall government proposal?
Yes.
Is that, was that proposed to be allocated to the mayors?
It's higher. I mean, you know, there's so the total would have been over $1 million in the total gaming, because
so
for
part of it.
For 2018, I believe we received almost I think like maybe 1.9 million from the limited gaming, but that could have been an accumulation from previous years, because what happens is...
No, I'm not asking about the allocation from previous years or the allocation by statute. I'm just asking, in the 2020 budget proposal, are we taking that limited gaming money from someone else? Or is it, or did you find it to be extra?
I think that's the extra amount.
Okay. All right. And then just to clarify, so we talked about this chart. It says revenues, expenses, and patient census.
Yes.
And then there was some discussion about, you know, when GRMC opened, did that increase or decrease the demand for beds? But if patient census, what does that mean? Amount of patients that GMH is taking in?
Yes.
So it does show that it actually has been decreasing.
Yes, and then it's starting to go up again towards the end of last fiscal year.
Okay,
August,
so that's
September,
not
it's going
part
up
of this
again.
chart. So at the end of this chart, it's still decreasing. That's FY 2018. So
Yes.
I see what you're
Right,
saying.
and the admissions for this year is projected to be 9,600, and I
Going up.
think, yeah.
Okay. All right, that clarifies then, because
Yes.
it doesn't match what you were saying versus this chart.
Yeah.
Okay, that's great. And then, Could I just ask, so for the maternity ward, maybe Benita, you know this, who negotiated with USDA? How did that project get chosen above all the other projects at GMH to talk to USDA about?
I thought that that was the legislature that identified, right, the funding to go to USDA for the maternity ward. That was like a couple
But
years ago.
I know the funding, yeah, okay.
Yeah.
Well, I thought it was a hospital-driven priority, but, all right, we'll look at that
Maybe
some
Dr.
more.
Shea?
Okay, what about, how much have you saved by not contracting out collections? What did you used to spend on that, and you're saying now you're not doing that?
I mean, we just started that with the AG's office
Yes.
just recently.
Right, so the OPA audit says you had not contracted out or sent any cases to your contracted attorney or collection agency, but how much do you spend normally? When you were using a collection agency, what did you spend on that?
They keep a percentage of about, I believe it's 30%, so it's not really a whole significant amount, but, after several tries, they return accounts, but it's because they couldn't collect anymore, so, we...
Do you have an amount of estimated, like what do you set aside for that normally? What would you set aside for that if you weren't able to use the AG's office?
Well, we don't set aside because it's
coming out of uncollectibles.
It's the collection that they collect, and then they keep a portion of the proceeds that they collect.
All right. The reason I'm asking is because the AG's doing that pursuant to a supplemental appropriation we gave them last year for, it was primarily intended to collect taxes, but we're glad that they're able to also help GMH collect hospital. I think they've been successful with DOA also collecting, bad checks, other things, but I just wanted to see if that needs to be allocated somehow. What about, okay, so we asked about the Medicaid and the, all right, so that's all my questions, except for the items that we've asked you to report to us, please.
And that's on the DLC, and also you want a list of the accounts payable, so we'll provide that.
That'd be great, thank you. And but I too want to commend you. I think your presentation's been very clear, very consistent across the board, which is very helpful. The consistency, it's been consistent with what you said in all our previous hearings, so thank you for that. That's very helpful. It helps, I think, all of us to get a very clear picture. It also helps us to go out on a limb for $60 million somehow. We're going to have to try to find that in order to, and so you've been successful, I think, in convincing us of the priority. Yeah, to put it in perspective, we're going to go out for a bond if Senator Perez's bill passed for $30 million. That's to open up one more cell at the landfill. Yes. And so, yes, I agree with Dr. Berdalia's description that, well, she's made it sound like this is not just we're spending on one item. We are really investing. It would be an investment on the long term to really, regardless of whether we build a new hospital or not, we need this investment. It looks to me that we cannot make it up any other way. We can't, I don't think building a new hospital would get us out of the need to fix the roof almost immediately before the next rainy season, and it will not get us out of the need for that electrical panel, because we will need to use this hospital for a few years regardless of any other dream or plans. And so, yeah, it's actually not that much money, the 11 million at least, right? The amount of money on electronic systems, it might just be because, we're old people up here, right? For me, it sounded like a huge amount of money. I remember last year's budget. That was the hugest part of the presentation. They really hammered that into us, and I was just furious almost, because I couldn't believe we're going to spend money on that system versus, because we did have people saying we needed another machine, such as an MRI, and we needed this machine, or we needed these direct patient care items urgently. And so think that very consistent message as to what is actually urgent, and it's been very, very helpful. And I want to thank you for this. The budget does seem thoughtful also, very much based on a very careful analysis of all the needs. And so I agree with Senator Perez that it does not reflect all your needs, and it's not a dream list. It's actually a very pared down, requirements, and that hopefully is going to directly address CMS issues, which I think is a perfect way to do the budget right now. And so I thank you for that. So I'm not in a position to promise how we're going to find this money. I think you need to keep pushing every other contact you have. I'm going to go look again at everything we've ever had on top of our desks to see how we might do that. But I do agree, and I think you can help us to get the governor to agree that if we have to be creative to fund this, we are going to have to do that. And how urgent we have to do that depends on how urgently really you need that data system to change over, right? Yes. Thank you very much.
Senator?
Yes, ma'am.
Yeah, I wanted to make a comment on, thank you for recognizing that we pared the budget down. When we met with all the different divisions, we started out with 154 million in operating budget. And, we looked at what we spent in 2018, we looked at what we're spending to date, projected to the end of the fiscal year, and that's how we were able to pare it down to the 134. So this budget that we presented is frugal, because we even included the certification pay or the differential pay for the nurses. So that one is very important for GMH too, so we can continue to recruit and not lose any more nurses. Thank you.
Okay, I just wanted to, I was speaking to Senator Sabina on the side here. The landfill bill, the bond, I'm going to bring it up on Senator Perez's. It's a $30 million bond, about $3 million a year for the 12.5 years we have to pay every year. And I'm just trying to picture how, because when I'm looking at your numbers, 21 million, 5 and 6, that's 32, 33. You can always shave that off, because if you get the insurance people to maybe repair, it may come down to maybe less than 30. And we bring it down, because I noticed there you have a lot of important things that you didn't mark as urgent. I see it at SNU. Like I said, I've got family that's up there. I visited them recently, and I'm like, I've been to the emergency room, and I'm like, there's some things, for me it's urgent. For you, maybe it's not as urgent, the way it's listed here. For doctors, I know everything here is urgent, but I just wanted to mention that, and there's no one else to testify, and just to give you fair warning that we may call for a round table to discuss other issues that the oversight or any of the other my colleagues may want answered. And if you can, please, when the Office of Finance and Budget calls and asks for some info, provide it before we call you in for an oversight. We just want to work with us, because we want to work with you. And I know that Yuko will have any problem, because it's just former OPA people anyways over there, so there shouldn't be any problem. There being none, the committee will conclude this budget hearing. The time now is 4:34. The committee will continue to receive testimonies until we present the budget. Okay, so we'll be still continuing communication. And then when you do submit, please address your written testimony to the Committee on General Government Operation, Appropriation, and Housing, and submit it via email to Senator Joe S. and Agustin. Jesus Masi, for your attendance and participating in today's hearing. And for those at home, thank you for watching. It is now 4:34.
Thank you, Senators.
Good afternoon.